Here's another situation. This actually is probably a little more closely, closer to kind of what this potential model could be like. This is a hospital in Artesia, New Mexico. I don't know if y'all are familiar with New Mexico, but it's in the southeast corner of New Mexico. I used to have to actually fly into Lubbock and then drive 180 miles across the desert to get to the facility, but now there's actually direct flights into Roswell. This hospital is a community-based hospital, not-for-profit. It actually is surrounded in Roswell, Carlsbad, by for-profit community health systems. And this hospital, quite frankly, over the last several years has just been moving market share to Artesia, New Mexico. And you can say, how did they do that? Well, there is a hospital district, very similar to yours, very similar. We actually lease the facility from the hospital district. We pay, in New Mexico, you have to kind of pay a state lease rate that's approved by the state. And we actually created a 501c3 local board that is comprised of community leaders, physician leaders, and also we have one of those seats is from the district board. So there is a district board member on that 501c3 board. About 5 or 6 years ago, the hospital had about 5 days of cash on hand. And the way I look at it, that's kind of like fumes. You know, that's basically how we're going to make payroll and so forth. We actually worked with the district. The district actually helped expand the hospital. You can see this is kind of the new part of the hospital. Added about 100,000 square feet. Renovated part of the old hospital. But over the course of time, we actually have recruited physicians into that marketplace. Cardiology, urology, ear, nose, and throat, general surgery. They actually did not have a full-time general surgeon, primary care physicians. And so it really, again, it's focusing on that medical staff development. Again, at the end of the day, none of us could admit patients or do procedures. We need physicians. And so, and if you think about it, Artesia would be a very challenging place to recruit doctors to. I mean, those of y'all are familiar. It is not what I call the guardian spot, in the United States. But quite frankly, over the last several years, we have been very, very successful in recruiting doctors to that community. And quite frankly, the reason why is because there's an exciting vision about the hospital. And actually what's happened over the last 2 years, some of the doctors that have actually been practicing at the CHS hospitals have actually migrated to Artesia, and we've brought them onto our team and to our staff, and it's been an amazing evolution. So that's a little bit. You can see the quote from Kenneth Randall, the CEO there, and it really is to me, it's a very, very exciting success story, quite frankly. And then the fourth example, the St. Mark's Medical Center. I think Mike touched on this, or Cindy did. It's about an hour drive outside of Austin. They were a standalone community hospital. The hospital board, it used to be called Fayette County or Fayette Memorial Hospital. It was kind of in town. It was the building was very, very outdated. And the local board said, we really need to do something. We're going to have to do something. So they actually went to HUD. We actually have several more hospitals that have gone to HUD and procured 242 financing, which is available to hospitals out there that basically maybe don't have the credit rating to go to the market to get debt financing. But anyway, this is before CDC. They actually built a beautiful new facility, and they were struggling. Their CEO actually became ill. They lost their CEO, and it was kind of floundering. So they actually approached us about coming in with a relationship, work with that local board, and you can kind of see what's transpired over the last couple of years. This is one of those ones where we actually became the corporate member of the 501c3. You can say, well, what's the benefit of that? Well, just to give you a couple examples, we could do managed care contracting. We could actually provide legal services as a part of our relationship with them, so that instead of having to pay for outside legal counsel, it's actually part of that relationship. Supply chain, being able to buy supply items at the best price on the marketplace. We actually, with our supply chain, some of the physicians on the district board, we actually, through our supply chain relationship, we actually can extend that pricing to doctor clinics where they could actually, through the relationship of being on active staff at the hospital, could actually buy their supplies from the GPO at the same price our hospitals are paying for the per unit basis. So it really is, again, that physician partner, hospital partner perspective. We actually did a look at the market and said, okay, where are the patients that they're not being taken care of in LaGrange? Where are they going? Well, it makes sense. They were going to Austin. Where are they going to in Austin? Obviously, there's Seton Health System or St. David's Health System. The majority of them are going to St. David's. So we actually said, okay, we approached the medical staff, approached the board, see if, to test the interest of, would you like an affiliate relationship with that St. David's Health System? So through that process, we struck a relationship with St. David's where they have one seat on the board. They attend our board meetings. And again, as Mike mentioned, Cindy mentioned, it provides some clinical protocols and some quality relationships, some education for the medical staff, for the employees. They have an OB program. And one of the things, how do you keep nurses current? You know, kind of some of those tougher cases that may happen. Well, the nurses there go to St. David's where they're delivering several hundred babies a month, and actually rotate with the OB nurses there in the St. David's Health System and bring that knowledge and that clinical training back to LaGrange. So those are some of the things where it really makes some sense. St. David's, one of the things that was very important to that local board, that 501c3 board, we really would like to have St. David's on our sign. And so about 6 months or so ago, we actually unveiled a new sign that actually is still St. Mark's Medical Center, but on the bottom it says a clinical affiliate of St. David's Health System. And that was very important. The board and the medical staff felt like that would kind of help put that good housekeeping seal of approval on the hospital. So you can see when we got there that they actually had negative cash flow. And 2011, 2012, we actually turned them into the black. Again, as Mike said, the way we do it, we maintain local banking relationships, and those funds, anything that's generated as excess earnings, actually stay in that community. Okay, at this point in time, see if there's any questions, and we'd like to entertain. Mike may have a couple of closing comments.
Yeah, just a couple of observations. You might be saying, why would these folks drive from Plano or Dallas or wherever we are to Crockett, Texas, and make this presentation? First and foremost, it's part of our mission. I mean, serving and supporting community hospitals is the reason we were created. And that's part of our mission. And having a relationship with your organization on behalf of one that we already have a relationship with, I think would be beneficial to both. You might ask us, do we think your hospital has a successful future? Well, we could all go around the room and give you different reasons why we think you do. And the most obvious is this facility in which we sit. And the array of physicians and other medical services that are lined up right down this highway and behind the highway. I mean, you have all the components, all the pieces of a pretty complex puzzle to be extremely successful in our case. The third reason that we think that you would be successful is we know by virtue of reading in the papers, and you're a public taxing district, and so consequently we get to know who has come before us and made presentations. And we know that there are some investor-owned corporations who would very much like to come and effectively lease your hospital for a lot of money, put the money into a foundation, and effectively control it for the foreseeable future. Now, that's a decision you're going to have to make, but that is the antithesis of what we stand for. We stand for community control. But their interest here tells us that there is tremendous, not just financial success, but tremendous success for healthcare delivery in your community. Now, those organizations wouldn't be lining up to make proposals to this board. Just as my closing comment, I'm going to take you back to that flower pot. For me, at least, and particularly for folks like you, there's lots of proposals and diagrams, etc. I want to take you back to the concept of flower pot. And every time you walk outside this beautiful time of year and you see a flower pot with flowers growing out of it, I want you to think of CHC. I want you to remember that CHC is the clay pot, and the soil, and the water, and the fertilizer. And your hospital is that beautiful flower that's coming out of the pot. You are the board that might be appointed are the gardeners. You're the only one who has authority to pick the flowers. We can take no money other than what you allow us to take. We can do nothing. We can't put extra fertilizer on. We can only do what the district and the local hospital board and the medical staff, all the gardeners, allow us to do. We really exist to support and make your institution successful. And with that, we would be happy to answer any questions that you might have. Yes, sir?
How do you feel the ACA is going to affect the commencement of hospital.
I'm sorry?
The ACA, the Accountable Care Act.
Yeah.
How do you feel that's going to affect management of hospitals, community hospitals?
Well,
They seem to have the most to lose.
absolutely, and let me ask my colleagues to join in on this discussion if they'd like. First of all, the Accountable Care Act's a reality. Right now, it's a reality is sequestration. Sequestration is going to cut 2% from your Medicare payments beginning April 1st from the hospital standpoint. And there are a number of things that coming in 2014 will potentially cut reimbursement for the patients that you see in both the inpatient and the outpatient setting. However, the other thing that's coming this fall is the opportunity for the federal government to come in and to provide insurance exchanges for those individuals who cannot afford insurance themselves, whose employers don't offer that insurance, and who are not eligible for Medicaid. Now, you all appreciate the fact that our governor has, in his wisdom, decided not to expand the Medicaid program in the state of Texas. And so consequently, a lot of folks who come to your ER who otherwise would have been Medicaid qualified and some level of reimbursement provided for will not be qualified. So there are going to be those individuals, though, who this fall go to the federal insurance exchange that's going to be offered in the state and buy insurance. We actually met today with our benefit planners at the CHC office. And that's the one other thing we probably should say. The lease of our lease of your institution would be to make your employees eligible for participation in our benefit programs, which are very attractive. But we met with our benefit planners to say, do we believe there are going to be more people enrolling in these insurance exchange programs coming to our institution? And we so much believe that the stock analysts who only investor-owned or who advise only investor-owned hospitals have given a positive impact of the Affordable Care Act to for-profit hospitals, because there are going to be more people who would come to the emergency room without insurance who will now come with insurance.